Assalamu alaikum, the long clinical consultation day. First scenario, Mr. Parker, 32 years old male. He presented with the complaint of short of breath. Please take history and examine the patient. Yes, here you go, Dr. Duria. Dr. Duria, you can start.
Hello.
Hello. Hello.
Hello.
Yes. Dr. Duria, please check your internet. We cannot hear you well. Dr. Duria?
Hearing well, but I don't know. My internet is not active well today.
So what you can do now? Can you fix this problem or other candidate can replace?
I
think
will enter again, but
you should
my
log in.
internet is not good. It's not good enough today.
You should log in again. I think you should log in the link again.
Okay, Dr. Duria, please check again. Log out and log in again, and we'll try to restart the session. Okay? Just give me the okay when you are ready.
Do you hear me, Dr. Basim? Do you hear me all?
Yeah, now it's clear. Yes, now it's clear. Okay, you can start now. Go ahead.
Okay. Hello.
Hello.
My name is Dr. Muhammad. I am one of the doctor covering the hospital today. Am I talking to Mr. Baker?
Yes, I am Parker.
Back. Mr. Parker, we are here together to discuss some issue related to your child, to take history and to make examination. If you don't mind, Mr. Parker.
Yes, please.
Tell me, what is your, tell me what's going on with you, Mr. Parker?
Well, doctor, as you can see from the paper, I'm having problem with my breathing. I am now finding it hard to catch up my breath.
I am so sorry for that, Mr. Parker. When did it exactly start, Mr. Parker?
Well, to be honest, doctor, it has been there for around 8 to 9 months. But just recently, I've been noticing that whenever I'm doing something or about to do something, or I try to, move faster, with a little exertion, I feel that I'm difficult to catch up my breath.
Okay. Do you notice any variations throughout the day? Is it increasing at certain time in the day, Mr. Parker?
Well, doctor, when I'm exerting, when I'm trying to, for example, run up the stairs, when I'm trying to run towards my car so that I don't get late. So when I'm exerting, I feel that I'm finding it difficult to catch up my breath.
Okay. Is it associated with cough, Mr. Parker?
Sorry?
Is it associated with cough?
No, I haven't experienced any cough.
Okay. With which number of pillow do you lie down? Number of pillow.
Well, I'm lying down with my normal pillows, doctor. I'm not experiencing any such thing.
Okay. Do you notice any swelling in your lower limb, Mr. Parker?
I haven't, no.
Okay. Do you have fever? High body temperature?
No, doctor.
Okay. Do you Is it this shortness of breath? Is it improved with? Do you not see anything that improves this shortness of breath?
I don't know, doctor. I haven't noticed anything. But I know that when I'm exerting, when I'm doing some work of effort, then I'm feeling that. Otherwise, I'm not feeling that much.
Okay. Okay. Yeah. Okay. Um. Do you notice any change in your body weight, Mr. Barker?
No, doctor.
Okay. Do you notice any change in your water work?
No, doctor.
Okay. Uh, Also, do you notice any change in your emotion? How emotion, Mr. Barker?
It's normal, doctor.
Normal. Okay. Do you feel chest pain, Mr. Barker?
I can't call it chest pain, but I feel like something, the shakiness in my heart, as if my heart is shaky sometimes.
Uh, uh, okay. Do you aware about feet?
Sometimes, yes, you're right. I feel that I'm aware of my beat sometimes.
Okay. Uh, uh, with which I mean that this you notice heartbeat when you are at rest or when you do some exercise.
Well, as I told you, when I'm exerting, about to do some exercise, or run, or hopping into the bus, or running up the stairs, any activity of exertion, I feel that.
Okay, okay, Mr. Parker. Uh, 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 are you? If you don't mind, I want to ask you some social question, Mr.
Please.
Parker. Do you smoke?
Sometimes I do smoke.
Okay. How many cigarettes per day do you smoke, Mr. Parker?
Not a regular smoker, but I do smoke a stick or two sticks. I mean, three after 2 3 days.
Okay. Do you drink alcohol?
No.
Okay. Um, do you have any chronic illnesses, Mr. Parker?
I don't know, doctor. I don't have any.
Okay. And do you have any chronic medications, chronic medicines that you take?
No, doctor. I don't have.
Okay. Uh, uh, Within period, if as you said, Mr. Parker, you have these since 9 months ago. Do you seek any medical advice during this period?
Sorry, medical advice during that period?
Yes. Yes.
Doctor, I don't like going to hospitals. There was a time when I felt like as if I'm going to, pass out. 2 or 3 times it has happened many months ago. I was like, someone told me, let's go for football. I was trying to run for the ball, and then I was feeling that I will pass out. And the friends told me to go to doctor, but I hate going to doctors and hospitals, doctor.
You said that you pass out while you are playing football.
Yes, I was about to
You,
pass out. I felt like I'm passing out.
okay. Is it the first time or recurrent multiple times?
I think it has happened 2 times roughly in the last 1 year.
Okay. Um. Are you aware about this? I mean that you regain your awareness immediately after passing out, or what's happened?
I didn't pass out actually, but I felt like I will pass out, you know?
Okay, Mr. Parker. Is this associated with body shaking body,
No,
shaking your body? Not
no, no.
associated with not shaking your body. Do you during this period do you have any headache?
No, doctor.
Okay. Uh, okay. I I want to examine you, if you don't mind, Mr. Parker.
Please, please.
Okay. Okay. I want to take your pulse.
Yeah, it's a kind of a jerky pulse.
Turkey pulse.
Yeah.
Okay. I want to take your blood pressure.
It's normal, slightly on higher side, 130 by 90.
On both sides, right and left.
Yeah, it's equal. It's all okay.
Okay. Okay. I want to examine your eye for any pallor, any jaundice.
It's normal.
Normal. I want to examine your mouth for any. I want to examine your mouth, oral cavity for hygiene. Central
It's normal.
cyanosis.
It's
Normal.
normal.
Okay. I want to examine your neck for lymphadenopathy and parotid enlargement.
Normal.
Okay. I missed that. I want to examine your hand for palmar erythema,
Normal.
clumping in your finger,
Nothing.
ulnar node, Janeway lesion.
It's not there, doctor. Nothing there except the jerky
Okay.
pulse.
Jerky pulse. Okay. I want to examine your chest, your precordium.
What do you want exactly to check? My
First, I want to check the apex.
Yeah, it's like
Character,
a
size.
it's like a triple ripple, you know? 3 ripples, double apical.
Okay, 3 apical. Okay.
Double
Uh,
apical,
uh,
double apical, or you can call it a triple ripple, you know? 3 ripples.
okay. The character. The side of apex.
It's a normal.
Normal.
Yeah, it's a
Okay.
normal size. Normal place.
Okay. If there is any, I want to palpate if for any thrill, palpable thrill.
None.
No palpable thrill.
Yeah,
Okay. For palpable B2.
nothing.
Okay. I want to auscultate.
Please.
For apex. For S1. First heart sound.
You can hear, kind of a crescendo, decrescendo murmur, what you will call it. Increasing and a decreasing murmur.
Okay.
Yeah.
Okay. Increasing. Is it related to any area in the
No,
chest, like a chest and neck?
no, it's not radiating to any.
Okay. If there is any murmur, I want to auscultate for murmur also.
I told you, doctor.
Okay, yes. I want to auscultate for second heart sound, pulmonary part and aortic part.
Non-specific. It's normal.
Okay. Okay. I want to examine the abdomen. I want to palpate for hepatojugular reflex.
It's not there.
Yes, there's hepatojugular reflex.
No, it's not there.
It's not there. And I want to complete my examination by examining the lower limb for lower limb edema.
It's normal. Nothing there.
No, okay. I want to auscultate for basal crepitations.
Not there. Normal.
There is no basal crepitation.
No, it's not there.
Okay. I missed that. I want to also assess for raised JVP.
It's normal, doctor.
Okay. Okay. Only positive is crescendo, descendo, murmur, and okay. 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 I'm presenting Mr. Parker, 34 years old patient.
Dr.
Presented
Doria,
short.
still you have 2 minutes still. You want to ask about concern? You want to ask about anything else? Examination,
Yes,
history?
yes,
Still
yes.
you have
Okay,
time
okay,
before presenting.
okay. Mr. Parker, do you have any concern?
Doctor, what's wrong with me? Am I going to die?
Okay. I really appreciate your concern, Mr. Parker. It seems that you have disorder. It seems that you have a disorder in your heart, being enlarged more than size, enlarged in size, responsible for causing chest pain, shortness of breath, and responsible for passing out that occur several times for you. It means that the heart is have been extra size.
Okay.
Do you understand me, Mr. Barker?
Yeah, I'm getting you. Am I going to die, doctor?
No, 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 no. I really appreciate your concern, Mr. Parker. If you receive the adequate medications, being under follow-up, you will live in your normal life.
Okay. So do
Okay.
you want me to get admitted?
We want to do further investigation to confirm the underlying diagnosis, and then to determine if you to be admitted or not.
Okay.
Okay.
Okay. Now please present the case.
Okay. Mr. Parker, 34 years old male, presented shortness of breath, including with exertion, associated with chest pain, associated with syncopal attacks. On examination, there is there is abnormal pulse. There is crescendo descendo murmur, that most likely to be obstructive cardiomyopathy for differential diagnosis.
Okay. So differential diagnosis, anything.
Diagnosis obstructive cardiomyopathy from clinical presentation and clinical presentations and history most likely to be hypertrophic obstructive cardiomyopathy. How come?
Okay. Good.
For further confirmations.
Would you like to offer some differentials?
Yes, aortic stenosis, hypertrophic aortic, the first differential diagnosis, hypertrophic obstructive cardiomyopathy, aortic stenosis, aortic stenosis. Okay, I think hypertrophic obstructive cardiomyopathy and aortic stenosis.
Okay. Okay. Tell me, doctor, tell me, how would you investigate?
Okay, we will start with ECG. Okay, we will start with a baseline blood investigations. Investigation to confirm the underlying diagnosis. We will do ECG, echocardiography, and even we need to do cardiac catheterization for further confirmation. Okay, these investigations.
Okay. Anything else in investigations that you will do?
I think baseline blood investigations, see complete blood counts, okay, RFT, renal function test, LFT, okay.
Okay. Doctor, tell me about medical management.
Okay, medical management. Okay, medical management for this condition. We give a number of medications. Okay, we give anti anti antiarrhythmic agents like amiodarone because those patients high risk to develop arrhythmia like VTAC and VF. Therefore, we give an amiodarone. We give also we will do implantable cardiac device also for those patients to prevent arrhythmia. We will give also beta blockers, and we will give prophylactic antibiotic to guard against infective endocarditis. Therefore, ICD, amiodarone, and prophylactic antibiotic for infective endocarditis.
Okay. Okay. Doctor, can you tell me if, for example, if do you have any other therapy in your mind? Anything that is apart from medications and apart from ICD?
Apart from ICD to be given to those patients, digoxin. I think that digoxin.
Why do you feel like you would be giving digoxin in this case?
Because those patients promptly develop arrhythmias like VTAC. I'm not sure.
Digoxin
I'm
is
not sure.
digoxin.
I'm
Okay.
not sure. I'm not sure.
Oh, okay, good. Okay, خلص.
Okay.
Okay, you can comment, Dr. Ibu now.
Okay, I think we are all in same boat, and we all are learning, and well attempted. It was a case of hukam. You arrived at your thing. You arrived at your diagnosis, and slowly you will try to modify your history taking, because we all are learning. So whenever someone is telling you about, something like shortness of breath, you have to ask about, the systems involved or systems related to it, neurological, and then regarding heart. You asked about the pillows, that's good, but then there are so many things that you could have asked, and when I told you about pre-syncopal, okay, and then coming to the point, something that you missed here was asking me about my family history. You arrived
Yes,
at
yes.
you arrived at Hukam, and in my heart, I had that thing that if you would ask me about family history, I would tell you that my cousin, my uncle, they drowned, and one had an unexplained car crash. So nobody knew. But at the end, it was found when autopsy was done, and they had. I would have told you that thing. And plus, coming to the point that pre-syncopal things that I mentioned to you, what am I doing? What am I doing to work? Is it impacting me? Uh, the review of the systems should be a holistic, any kind of approaching everything from all sides, knowing the fact that this is a I'm giving you a case of shortness of breath. So you can ask me so many things. Shortness of breath can come in, and I'm a young a person. Mr. Parker is a young guy, so many things you could have asked. Well done. Anyhow, then coming on to the point that you are doing physical examination, I give you a clear indication, jerky pulse, or you can call it a double tapping, or what that is. And then there is an apex beat, which is a double apical impulse or triple ripple, they call it. Yeah. So did you check the lungs? Yes, you asked crepitation. You asked about crepitation. You asked about GVP. You asked about it twice, by the way. Hepatojugular, you did. Looking at the skin, looking at the oral area, that you did. Okay. And there is no need of doing dynamic maneuvers, by the way. In this case, you asked whether it's radiating to carotids. That's a good thing. And it was a case of hukam. It was a case of hukam. And in a differentials, you can say that severe valvular aortic stenosis, it can be hypertensive heart disease, it can be physiological left ventricular hypertrophy or athlete's heart, and then it can be infiltrative or storage disease like Fabry diseases and cardiac amyloidosis and Friedreich ataxia. They are all hukam mimics. So these are the list of differentials. And then coming on to the investigations, whenever someone is asking you about investigations, you are supposed to give them the investigatory findings in that particular line. For example, if you are telling ECG, you try to mention that you will check Q waves, because they are going to be very significant in this case. That's a typical word for use, dagger-like Q waves, and deep T-wave inversion. And there is a, since the muscle will be thickened, so there will be prominent left ventricular hypertrophy voltage criteria. So, and one of the very symbolic investigation that you would do in the Hukam is echocardiography, because in that you will see SAM, systolic anterior motion. There was a mnemonic we used to do in MRCP 1 and 2. There was a mnemonic about that, SAM ASH or something like that. So SAM, which means systolic anterior motion of the mitral wall leaf knocking against the septum. So that is something that you will see in the echo. And because of that motion, there is left ventricular outflow tract obstruction, and that's mitral regurgitation. So I'm not asking you about the whole thing, but I'm asking you echo. In echo, you will see SAM, systolic anterior motion of the mitral wall leaf. Then you can do, MR, SAM, ASH, mitral regurgitation, systolic anterior motion of the mitral wall, and hypertrophy, asymmetric hypertrophy. Then you can do MRI. Why MRI? Because if it's a case of amyloidosis, if it's a case of depositing disease, or the disease that I mentioned as a differential, you will see them with the gadolinium enhancement. Then you can do 24 to 48 or Holter monitoring. 24 to 48 or Holter monitoring is a kind of investigation that you will mention in any case where there is a element of presyncope or syncope, where there is a case of a young guy coming to you with a complaints of exertional, and you find an element of heart related to it. This is a mandatory mention for any investigations. And then you can offer genetic testing, because if you have Hukam in your mind, genetics will reveal that there is a problem with the sarcomeric genes. Then medical management, you were right. There is a non-medical management, there is a medical management. Non-medical management is like not allowing them to do exertion. And by the way, in such case, when someone comes to you, and you should tell them that, yeah, first I will, ideally, you're not admitting the person, but it would be ideal to admit the person to run these investigations, and then do an MDT. MDT, you will always mention MDT. In such cases, you will have to mention MDT. So medical management here, when we talk about medical management, the first and foremost thing that you mention is beta blockers. Beta blockers. Why? It will reduce the heart rate, and it will lower the exertional outflow tract gradient, and it will improve the coronary perfusion. Then if beta blocker is, if the guy is asthmatic or any other issue, then you can use the non-hydropyridine calcium channel blocker, verapamil. And there is a new drug. I don't know, Dr. Basim sir can tell us whether we need to remember that or not, but people say that there's a new drug, and sometimes they ask about it. In some places, I don't know, they have asked it. Mavacamten. They've asked about this Mavacamten. It's a myosin, cardiac myosin inhibitor. Since the problem is within the cardiac myosin, you have to mention.
Yeah.
Now, the important thing is what you do not give in this case. You are not supposed to give anything that is vasodilator, that reduce the preload, that reduce the afterload, like AC inhibitors, like nitrates, like amlodipine, like high dose of diuretics, high dose. So yeah, why? Because it worsens the obstruction. Then you are, by the way, very good. You said ICD, something that you have to give when you know that when it's a case of a primary, when the LV thickness is very high, when there's a family history in first degree relative, then you can jump to these preventive measures, or when there is non-sustained VT, and at the very end, septal myectomy, surgical septal myectomy, excision of the enlarged hypertrophied part of the septum. This is the gold standard for the young fit individual. Septal myectomy is the gold standard for young and fit individuals. And then there is something which they call infusion of alcohol, which is also called alcohol septal ablation. Yeah, that's my take on it.
Yeah, thank you, Dr. Ahmed.
Thank you so much.
Actually, my comment will be tough if I start to comment about Dr. Duria. But before starting my comment, please, Dr. Korea, can you post your scenario for Dr. Ahmed in the chat box?
Okay.
And for today's performance, I will not judge in the skills, okay? Because I can see that most of the skills is not fulfilled. Maybe practice first time. Yes, this is first time in my session, so I will be
Yes.
postponing the judgment in the another session to be more efficient. Okay, but I will
Okay.
comment on in the way that the history is interrupted many times. It will just give the examiner the impression that you are not ready for the exam. In the exam, you will not have the time to think what I should ask. The question should be very fluent, very fast, and no stop. You will not have the time to stop even. You will not have the time to think. So everything will pass subconsciously without thinking what I should ask now. Should I ask about this system or this question? No, it's a matter of rushing with the questions to know which is positive, which is negative, and gathering all the information. You will give the diagnosis at the end. So the first thing here, I will ask you how you know this is a case of Holcomb. The examiner, if you didn't show him the evidence, he will think that you give the case or the diagnosis by luck. So you said this is Holcomb. Yes, it's correct diagnosis, but how do you know it? I have some evidence in the history plus examination to tell about this diagnosis to the examiner and to show the examiner that I know the case from the history, from positive finding in the history. As Dr. Ahmed said, one of them, the family history. You didn't ask at all about family. So how you say this is Hokam? So the examiner again will say, maybe by chance he mentioned the diagnosis. Okay, although you mentioned the correct diagnosis, but still he cannot give you good mark because you didn't show him the positive finding in the history. So the matter is not knowing the diagnosis. The matter is to show how I catch the diagnosis. What are the positive findings in the history I get from the history to show the examiner that my history, my finding or the diagnosis based on this history. Oh. Just a minute. Okay, this is the first thing. The second thing, you have to know the full approach to be organized, which was totally disorganized. You didn't ask the systemic review question one by one from head to toe. You ask about short breath, then palpitation, lower limb edema. Yes, you ask other system like GI, urinary. But how do you know? Give me the evidence, Dr. Rodria. Why you know this is, or how you said this is a diagnosis of HOCM? How you catch it?
Uh,
From which point?
okay. From examination, he said that has a Turkey pulse, and I get diagnosis when patient said that has syncopal attacks. Due to small age, syncopal attacks, and Turkey pulse, and crescendo murmur from examination, all of these are consistent with Humcom. It is the first time for presenting long clinical consultation. Uh, I prepared for phases recently. It's the first time to practice in LCC.
You know, it's perfect if you mention like that you catch the diagnosis from these only words, although you didn't show the other positive finding like family history. Yes, syncope could be one of the presentation of HOCM, And by the way, family history will be the most stronger evidence in this scenario. He will tell you either sudden death at early age of his cousin or siblings, or the patient will tell you he had another family member who had heart attack at early age as well. But mentioning Hokam by this finding only, again, it could be by luck. It will not be that much easy. Although you didn't ask about all the systems. Anyway, as a first practice, as you said, first presentation with my session. I don't know if you practice also in another session. Anyway, it was perfect if you know the case from this finding. But still, it's not a matter of knowing the diagnosis. It's a matter of practicing and experiencing in front of the examiner what I should ask and how I should be organized. The way you follow the approach, you will show the examiner that you are professional, you have a lot of experience, a lot of practice in multiple sessions, and they can give you good mark. Okay, it's not a matter of
Inshallah.
diagnosis again. Differential diagnosis, of course, you have to have good differential. Okay, but again, it's good to know the HOCM as a diagnosis. Okay, let's go to. I think Dr. Ibu covered most of the points of the investigation, and as he said, don't say cardiac diagnosis without ECG and echo. It's something it will mark you down in the clinical judgment harmfully. It can be like borderline, or might some examiner might put unsatisfactory. How you can diagnose HOCM without ECG and echo? Okay, so put it in your mind whenever you have cardiac case, you have to give a specific investigation in the form of BMB troponin along with the EG and echo. It's a must. You have to mention it. Okay.
Okay.
Okay. Okay. Good. Dr. Ibu, your scenario. Margarita Higgins, 64 years old, outpatient clinic. She has been referred due to 3 months history of progressive short of breath, persistent dry cough. She noticed some generalized lethargy, denied chest pain. So it's the same system, short of breath. Okay. Any question from other candidate? Anyone want to comment?
بس كومنت صغيرة when she was
Sure.
giving
Yes.
الله يسعدك when she was giving the finding of the examination بس يا عسل حتى تتذكري إنه he was giving you the finding يعني in the exam as a let's say GP ولا general medicine you will not be able to get jerky pulse, you will not be able to get the biphasic apex. So that's why يعني it is important sometimes إنه the history and the risk factors تمام and whatever like some conditions they have triggers إنه they give you the clue about the diagnosis before reaching the examination, because all those typical signs which we usually study or we usually know that if those signs are there they used to help us in the MCQs because we are not touching the patient, and if we find them we call them keywords and we pick the correct answer. But in the exam remember even the site of the ejection systolic murmur you might not be able to determine where is the maximum intensity. And you are hearing something over the pericardium, but it is, except mashallah, and I don't know, you might be a cardiologist and this might be easy for you, but I mean regularly, normally for like everyone who's going to the exam, it is sometimes even difficult to do the timing. Take care and don't depend on the examination findings, especially the sophisticated one, like loud P1, loud P2, loud S1, soft, these things. We might give those findings while we are doing the case online. Why? Because we are willing to revise the clinical feature. Yani we want to keep hearing biphasic pulse, apex, jerky pulse. So we will keep those in our mind. But the reality, you might not find these things and you might not pick them, even if they are there. تمام? Because we're not used to. تمام. differentiate between biphasic or like the character of the pulse or the character of the apex. Sometimes really a good history is very important, and like the risk factors, the associated features, these stuff are very important. Remember one thing, sometimes, as Dr. Bassem mentioned, the family history is very important, but still having a good analysis of the shortness of breath is also important, because if it is exertional, he is young, tamam, he might tell you, I don't know my family history. I'm, for example, adopted. Sometimes this is by itself a clue for familial diseases. In PACEs, they have their own tricks. فمشان هيك you need to catch the disease by multiple ways. تمام. You should have more than one key question. Okay. For example, syncope, it is very important whenever it comes to HOCM or aortic stenosis. Aortic stenosis in elderly and HOCM in young, syncope will be positive. So you should really keep things in your mind, تمام? And more than one way to reach the diagnosis. Not if I didn't find a family history, I will exclude HOCM. It will not work like this. If I didn't find something specific, I will exclude this disease. For example, not hereditary, hereditary periodic paralysis. تمام. If I didn't find the previous attack, because it's usually in attacks, it is never hereditary periodic paralysis. But there was a doctor who diagnosed this condition from the first attack. Then there was a recurrence. Maybe you are the one. So never ever in PACEs, especially when I knew that it is your first practice, I felt it is good to warn you. Some people you practice with them, they stress on key things. Okay, key things are important, but I need 3-4 keys, not one, not two. تمام. History is very important, supported by examination, because we don't know, we might get a demo case, nothing in the case. We might get difficult findings, which we ourselves, we cannot pick. So we should really work on the history. It's not only the history, rather triggers, association, as Dr. Bassem mentioned, family history, تمام. Medication, sometimes they help. Lifestyle, diet sometimes is the clue. Anemia, and nothing in the case. Nothing. It's case of anemia. Only diet, vegetarian. Without the diet history, without knowing vegetarian, it will never come to your mind that I need to include vitamin B12 deficiency. Okay? The whole case, surgery. He did a bariatric gastrectomy. تمام. And without the history of surgical history, you missed gastrectomy and you're struggling with anemia case, you will not get that it is vitamin B12 deficiency, secondary to loss of intrinsic factor after they cut part of the stomach. So this is the worst part of PACEs, that you should practice too much in order to get those tricky stuff, where it is not about the history. You are perfect. You knew it's anemia. Without the surgical history, what type of anemia I'm dealing with, you missed it. And you will not be, they will not reward you based on getting its anemia case. So that's why really take care of the risk factor, association, surrounding circumstances. Those stuff are very important. Lifestyle, diet. Okay. And sometimes they take care of the welfare more than the diagnosis itself. Like, for example, HOCM patient. They will never be happy if you didn't ask about hobbies. Imagine you get a HOCM case, and you get the differential diagnosis very right, and you get everything. Welfare, you will lose it if the patient is a gymnastic or athletic or hiking. He do hiking? For sure, that nobody gonna give you even a simple smile to help you, or to give you, a positive charge so you can continue the examiner question. You get HOCM, the patient is HOCM, you did everything right, but they're still giving you that bad face. That's something very important, you missed it. Like hobbies. Okay, you missed hobbies, no problem. You should advise this patient by default. Please avoid traumatic activity, avoid high demand job, avoid high demand sport. if you didn't say this, not traumatic activity for APKD, just avoid high demand job and avoid high demand sport. And this is very important. Some advices and some lifestyles, it's really important. So always remember that whenever you do a case, never ever look at it as a case to get a diagnosis. Okay, you need the diagnosis, you need the cause, you need the complication, you need the safety advices, okay, and the welfare. And those are sometimes part of the judgment also, not only the welfare, that this doctor has a correct judgment and he's a safe person. تمام؟ These things all should be in your mind. That's why even though Dr. Bassem did not discuss or judge you based on the skills, but you should go and read them by yourself and understand what is the skills Dr. Bassem was talking about. Because really, diagnosis is one of the 5 skills you will be judged about. And all the others are like, do you know, also they are the way to pass the exam. And it is not like just the diagnosis which matter, or even the complication, or even the etiology. Everything matter. And if he is a tough examiner, he might make your life not easy. Even if you get a diagnosis, he might make it for you difficult to pass the case. It's not to make things difficult, لا. But sometimes if I know what I'm dealing with from the beginning, I will not waste time. Some people, they spend 6 months training themselves to get the diagnosis, forgetting that there are other important skills. And ya haram, if someone tell them about this from the beginning, they would deal with every case differently. They would spend more time with every case differently. Yani after our discussion now, you will go and read, for example, about patient advices. Just a second. Patient advices for every case. تمام. Patient advices for every case. What I should discuss with my patient. تمام. How is the counseling of HOCM. طبعا في مواقع كتير. There are many websites which like NHS, PMJ. So you will now take care of other aspects while you are studying anything. And regarding the medication Dr. Epo mentioned, the Mavacampton, I think, always try sometimes to touch هيك شوية updates. Sometimes whenever you do something not good and you get this bonus question and you answer it, it بتساعد تلطف الجو. تمام? I know it's not the best thing to do. يعني don't like, do you know, ما تقصري, يعني don't make things like not perfect regarding the skills and approach perfection regarding the updates. لا. But it is a good thing because Dr. Ibo, he asked like whether this medication is important or not. Sometimes really it makes the examiner happy that, okay, I'm dealing with a doctor who is like seeking updates, keeping himself oriented about any new drugs and these stuff. So always balance. The skills have the most important weight in your studies and touch any updates in the investigation, any updates in the management. Okay, any updates in the criteria? Any new criteria, guys, is very important. Like for example, in rheumatological disease. فبس وقت انتبهت انك بنوتة جديدة فقلت عن جد يعني to make things difficult for you maybe ولا easy, I don't know. بس يعني try really to بالعكس start correctly, let's say. تمام؟
Yeah,
Okay,
thank
thank
you
you.
so much. Thank you, Dr. Hind. Thank you so much. So kind of you, Dr. Hind. Really, I don't want to be very tough for her. That's why I didn't judge in her performance. But really, to be as a first practice to catch diagnosis, it's very impressive. But
لا لا حرام.
remember, as
I'm happy that
yeah,
she was like well oriented لأنه بالنهاية she's making her life easier.
yes,
يعني now she don't have to work on everything. ما شاء الله, she have a good knowledge, so she will have a chance to work even on other things. بالعكس, sometime I feel if you are still remembering the information of part 1 and part 2 and you by yourself is a knowledgeable person, this will make your life easier rather than seeking the knowledge and seeking the skills. Like running after the knowledge and the diagnosis and running after the skills. فلا, this will save you time. Sometimes even it save you 50% of the effort. But what I like to tell sometime when I speak about all this stuff, nobody is wasting time to tell us, take care. You need to look at this point. You need to, like for example, if you are taking notes about HOCM, so you would like to make a notes which will save you during the exam. So now you will spend, for example, 2-3 months. طيب النوتس اللي انا عملتها 2-3 months وما حدا حكى لي عن السكيلز، وما حدا حكى لي انه التروما والسبورت والهوبيز هي شو اعمل فيها؟ ارجع راجعها، ارجع اكملها يعني ارجع to work on notes I was doing for 3 months. For sometimes it is like good to make what we called eye opener stuff يعني. So sometimes there are many aspects in the case: party, drug, family history, hobbies, home circumstances, screening about, like you have to tell him in the closure, I need to involve the genetic counselor to look into the family tree to see who need to be screened. I'm happy I get HOCA. ولا بتعني شيء إذا أنا ما حكيت عن genetic counselor. if I'm sorry نحن عربي. If I didn't talk about the genetic counselor and involve the family screening. So those points, if they are not in your notes من أول ما بتعملي نوت الهوكم, you need to revise your notes maybe 50 times just to every time complete, because you're discovering something. فno, for every disease, for every note you will prepare from now on, you should take care about الحواشي اللي نحن شو بنسميها شو بيقولوا collaterals. They are more important sometimes than the diagnosis itself. From this point really يعني I opened this. صح كلام دكتور باسم, and like being in such a positive environment is very helpful. And whatever I'm saying is just because I'm someone who really prepared notes and he has to يعني to extend. Sometimes I remove the whole note and I rewrite it again. Take care of these stuff. Whenever you're starting, have a good start, complete start, effective start, تمام? But whatever you did in the case is perfect for first time. يعني always remember that some people, they are even like they get scared to even do a case حتى يوصلوا للdiagnosis أصلا. Whatever you're doing is perfect. Starting practicing is perfect. Reaching the diagnosis is perfect. Listening to me, صبرك علي ما قلتي لو سمحتي بطلي حكي، تمام؟ those stuff is really يعني perfect as a start. So you will have, like, let's say يعني less effort in your journey, يعني you will do less effort in your journey. تمام؟
Yes, some tips, Dr. Doria. Write these tips in your note. Believe me, those tips, whenever you wrote it by your hand, it will be forever for you. Not only as in the session and in the PACES exam, it will be even for the clinical practice. You remember those stuff, as Dr. Hind mentioned, the advices, the hobbies, which is something out of the box. Not everyone will think about it, and the examiner will be impressed by those things, not by the diagnosis. I catch the diagnosis. No, don't be happy. I don't think anyone will be happy if he knows the diagnosis without the important advices, or even the driving here. It's very important. I don't know if you discuss if he drives. It's very important to stop his driving, because one of the barriers here will be the driving. Patient cannot drive if he has HOCM, especially if he has one syncope attack. So the best advice to stop driving till he has the further management. Some scenarios will come as pilot, doctor, I'm flyer, or I'm working as a pilot. Can I proceed? No, please stop till further assessment. Okay. Thank you again, Dr. Hind. We just want to motivate Dr. Doria as a first time practice. Don't be afraid. Don't say, no, I will not practice again. No, you are welcome. When you mention or when you text me that I want to, you are welcome, Dr. Doria, at any time. Just write these tips in your note and get ready to the next practice, okay? Let's start. Yeah.
يعني really it is not about like بالعكس, whatever you will gain in practice, not gain it by any other mean. يعني for example now, just taking the steps and doing HOCM case, you get notes from Dr. Ipo, you get notes from Dr. Bassem, you get some input from me, you read some comments on the if you would be now alone and you read, for example, case of Holcomb, because you saw it in the recall, you would never have such an input, which is like about points, useful points. Try sometimes, even if you are like some people, they are hard on themselves. I missed a lot. Like I need to start from 0 point. But remember, you are saving effort rather than working on those points اللي أنا بصراحة even Dr. Ibo, Dr. Basim, we couldn't collect them from one session. Maybe it took us 1 year and a half, every time adding to our notes. You came now and you get whatever those people worked on just because you have the courage to go and practice. Being in such an environment is not to depress ولا to demotivate ولا to, just like teach حتى. And we don't have even the purpose of teaching. And I feel sometimes we are just like, having bad experience. We are trying not to make anyone have the same bad experience like us. We try, whenever someone is doing a case, لا, take care of this and take care of this and take care of this and make your notes perfect and right. Try whenever you are free, whenever, not only with Dr. Bassem, post in the group, anyone is free, practice. practice بيعمل مثل الحديث المقولة اللي بتقولك من استشار الناس شاركهم في عقولهم. فلما انت بتعملي براكتس عم بتلمي كل خبرة الموجودين هدول. try always to really practice, try always to be in touch with others. Don't say this is a mature candidate ولا this is an old group ولا no. أهلا وسهلا فيكي، واللي ما بيعجبه لا يرجع يتدرب يعني معك. يعني إذا في حدا مثلا he wants something specific but you always offer, you always take the steps. ويعني كدكتور باسم كجروب I think it is the most positive environment to start with. Always remember, practicing will cut short the long way of cases. Really it will cut it short, especially لما بتلاقي حدا يعني he's listening and he's giving experience and commenting. يعني هذا someone who's really trying to save you some time, save you some effort. don't take it on your nerves. وصدقيني نحن كنا أسوأ منك وخابصين خبصات. يمكن حتى الهوكم diagnosis هذا اللي انت قلتيه يمكن إذا بتسمعي لنا ريكوردات قديمة بتلاقينا نحن ما عرفنا نقوله. never think إنه someone is perfect because he's commenting. All of us we have like سقطات ربنا أعلم بها. تمام. just like do it every time you have free time and try really to practice with many people, Dr. Basim and others, and try to take a good notes always. Notes كتير مهمة. تمام. not only notes about the disease, notes about advices or triggers, what he should avoid, what he should not. تمام. This is sometimes more important than the disease itself. With differential طبعا في too many people they fail in the differential. try to have a strong differential always for any symptom يعني, not only for the disease. لأنه الهوكم إذا إجا when هوكم is a chest pain you have like acute coronary syndrome. When hokum is, for example, shortness of breath, okay, you will have cardiac failure as a differential. When hokum is syncope, you will have aortic stenosis as a differential. تمام. فأنت بالنهاية you are giving differential based on the symptom sometime. تمام. take care of this stuff. يعني try to have a strong differential try to have a good notes. this is والله the aim of my advice. Otherwise يعني please ما بدي دكتور باسم يقول لي خوفتي يا للبنوتة.
No, instead, Dr. Hind, you are motivating here along with me. So again, you are welcome, Dr. Daria, at any time. But now we will listen to you as a surrogate. Let's see how you can do it. Are you ready?
Yes.
Okay, here you go.
Hello,
Hello.
I'm Dr. Ahmed, one of the doctor in the clinic today. Hello, I'm Dr. Ahmed, one of the doctors in outpatient medical clinic today. Am I talking to Miss Margaret Higgins, 64-year-old?
Yes.
Okay. How do you want me to call you?
Miss Margaret.
Okay, Miss Margaret, We are going to discuss something related to your health. I will note down a few things that will be confidential. Then I will examine you, and then we will arrive at some conclusion. Is it okay with you?
Yes.
Miss Margaret, your GP note says that you've been having problem with breathing for the last 3 months.
Yes.
Can you
Yes, doctor.
Yes. Can you elaborate it for me in your own words?
Okay. I'm suffering from shortness of breath since 3 months ago. Okay. And I feel this shortness of breath has been more severe in the last few days.
Okay. That must be concerning for you. I assure you of complete support, Miss Margaret. We will do something needful for it. Okay. So is it the first time you are having this shortness of breath?
Yes.
Okay. And you also mentioned that you are having persistent dry cough as well.
Yes, also.
Is it associated at the same time, 3 months?
Yes, it's present at the same time, shortness of breath and dry cough.
Okay. And do you feel that you see something in your phlegm when you're coughing out?
No, it's dry.
Okay. It's dry. Okay. Okay. You said you denied chest pain as well. So do you feel anything increasing your shortness of breath?
Yes, when I climbing stairs, I feel that shortness of breath is increasing more.
Okay. Okay. And do you feel something, any activity or maneuver that decreases your shortness of breath?
No.
Okay. And do you feel that you are short of breath more at night when you are lying down straight for sleep?
No. Yeah, it's static throughout the day. Yeah, it's static all the day. I have a shortness of breath, but as I
Okay.
said to you, it increases when I go in upstairs and doing some activities.
Okay. Okay. So, any problem with your eating or swallowing?
No. Yes. Recently, I feel some difficulty when I swallow food.
Okay. Okay. And would you put it into words? What kind of difficulty? Is it when you start chewing, or when you have chewed and it goes into your throat, then you feel it difficult?
I feel that difficulty when I swallow after chewing the food and I start to swallow it. I feel some difficulty.
Okay. And since when you are noticing this thing?
I noticed that in the last 1 month.
In the last 1 month. Okay. Is it particular to some variant of food, like uh, solids or liquids?
I noticed that seriously for liquid.
So you notice it what for liquid? It's more for liquids,
Yes. More
and
for
it's okay. And for solids, it's okay.
yeah. So it is some difficult, but for liquid more.
Okay. 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 So okay. Any racing and pacing of heart, Margaret?
No.
Okay. Do you feel like throwing up?
I'm not hearing you.
Do you feel sick or feeling to throw up sometimes?
Yes.
Okay. Have you done it? Have you thrown up any before?
I'm not hearing it. You, doctor, please repeat.
Do you feel that you have thrown up? Or
Any
have you thrown
vomiting?
up?
Any vomiting, Dr.
Any
Duria?
vomiting? I
Yeah.
was avoiding that word actually, vomiting
Yeah, but
actually.
maybe she doesn't want
Okay,
or
no
she
issues, no
doesn't
issues.
know about
I will
these
use it.
terms.
Okay. Have you vomited?
No.
Okay. And how's your bowel? Is it too
Uh,
hard or too soft?
it's too soft.
Too soft. Okay.
Yes.
Would you mention the frequency of passing soft bowels or soft stools?
About 3 times per day.
3 times per day. And is it
Yes.
watery or is it something with having jelly-like stuff in them?
I feel that is soft but not watery. Soft but not
Okay.
watery.
Okay. Is it related to your diet, your food intake?
No, it's not related to certain
I mean,
diet.
do you feel that when you take some particular food, it increases?
No, no. I think all type of food can associate with
Okay.
this loose motion.
Okay. Okay. Any tummy pain, Miss Margaret?
Yes.
Okay. Where and how? Can you describe it?
Yes. It feels like some generalized. Okay, it's not localized to certain area. It affect all my
Okay.
tummy.
Okay.
The character of this pen, I really can't describe. Can't describe that. It's something
Are
vague.
you okay? Are you in
Something
pain
vague.
right now? Is your tummy hurting
No,
right now?
no, 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 no. Thank you, doctor.
Okay. And on a scale of 0 to 10, with 10 being highest, how would you grade it? The pain, the pain,
Okay, I give it the pen 5 from 10. It's not severe.
5.
Okay, yes.
Okay. And it's generalized. Okay. Okay. Miss Margaret, you mentioned that you have progressive shortness of breath. Okay. Uh, is it impairing your activity, day-to-day activities?
Yes.
Okay. And what do you do for a living?
I work as a teacher.
Okay. It must be hampering your work, I'm sure.
Yes.
Okay. And do you have a partner?
Yes.
Stable? Okay. And is that partner supportive?
Yes.
Okay. Miss Margaret, do you smoke?
No.
Okay. And do you consume alcohol?
No. No.
Okay. Miss Margaret, do you have pets?
No.
Okay. And Miss Margaret, did you travel recently? Any travel that you would want to share?
I'm not hearing you, doctor.
Did you travel recently? Did you travel anywhere recently? Any air
No.
travel, any land travel?
No, doctor.
Okay. Are you having any medical condition that you would want to share with me?
Yes. I have a hypertension, doctor.
Okay.
I have been hypertension.
Okay.
And I also recently I feel like some regurgitation of food while I lying down.
Okay.
It just I have a high blood pressure and I have this regurgitation of food content while I lying down.
Okay. Would you mention the medications that you are using for your hypertension, that as you say?
Okay, I take amlodipine 5 milligram.
Okay.
And I take also for this regurgitation omeprazole.
Okay. And since how long you have been taking these medications? Amlodipine
Uh,
and
I take this medications, antihypertensive, for 2 years, but omeprazole I take it recently.
okay. And are you compliant to your antihypertensive medicine?
Yes.
Okay. Is it controlled normally? Are you checking it regularly?
Yes. Yes,
Okay.
it's controlled.
And you mentioned you started omeprazole just 1 month ago, right?
Yes.
Why did you start it? For this complaint of regurgitation?
Yes. For regurgitation, I feel that food have been regurgitated to mouse when lying down. GP prescribed it for me.
Okay. Okay. And okay. Do you have any rash on your body anywhere?
I don't have rash, but I feel that, doctor, I noticed some change in my finger.
Okay.
Uh,
Good.
some change in my finger. And
And
this is very impressing me, doctor.
would you mention what kind of changes?
I feel that they feel pain, severe pain, when I go in the cold weather.
Okay.
And I notice also some change in color. I feel that my finger looks like black, have different colors when I go
Okay.
also in the cold weather, doctor.
Okay, that must be concerning. We will do something needful for that. Miss Margaret, uh, when did you start noticing this in your fingers?
I noticed that within the last 3 months. I think it starts with the start with suspect and it starts with a dry cough. I noticed
Okay.
that they appear at the same time.
Okay. It started with a dry cough. Okay. Any problem with your hair? Any hair loss?
No, no, doctor.
Okay. Any sores anywhere in your mouth or any private areas?
Uh, yes. I noticed some change in my mouth also. It feels like soreness in my mouth, and I feel
Okay.
it very tough when I want to eat. I can't open my mouth.
Okay.
I can't open my mouth.
Okay. Okay. And how many kids do you have, if you may please tell me?
Well, I'm not hearing you, doctor.
How many kids do you have? How many kids do you have?
Okay, I have a 3 kids, doctor.
Okay, fine. And okay, I will like to examine you, please.
Okay,
Starting from the hands, I'll try to
okay,
look at the hands, the general appearance of your hand, the musculature and the skin, and any discoloration on the skin or any, any marks on the skin. I mean, vascular marks on the skin. Try to look at your nails.
2 minutes left.
Then I will try to feel the pulse.
irregular and
Okay.
normal in volume.
I will compare it. Then I will try to move up and look at the skin of your arms and up,
Yes,
up at the neck. I will try to look at the neck as well. Ask you to look at other side to see the JVP.
there is no JPP.
Okay, I will try to look at the mouth. As you told me that the mouth is, you feel difficulty in opening the mouth for food.
Yes,
And I will try to look at the nose, whether the nose is deformed or any skin tightening around it.
yes, there is skin tightening around the nose.
Okay, there is skin tightening around the nose. I will try to look at the overall face, whether there are any vascular marks or vascular lesions on it.
No,
Then I will straight away go to locate the apex. Is it in its normal place?
yes, normal place. Normal
Yeah.
place, yes.
Then I will try to, put the stat there. Move from position, mitral, tricuspid.
Normal. There is no normal heart sounds.
Okay. Okay. I will try to hear the P2 as well.
Yes, P2 is audible.
Okay, P2 is audible.
Yes.
Okay. Then I will try to put the stat on the base of the lung areas, the basal areas. Whether there are
There
any
is,
fine crepitations.
there is no fine qualifications.
Okay. Then I will try to put the stat on the apical areas.
Normal.
Okay. Then I will try to gently palpate the tummy. the superficial palpation, whether there is any organomegaly, or whether I can feel any lump.
Okay, time is up, Dr. Ibu. 1 minute for the concern, just to address the concern.
Okay,
and
tell me
we'll
about.
start this.
Okay, tell me about your concerns, Miss Margaret. Miss Margaret,
Yes.
may I know your concerns?
Please tell me, doctor, what's going on with me? Am I going to
Well,
die?
Well, from findings that from the history that I have taken and from the findings that I have seen from your examination, it seems that you have a problem with your tissues, from the connective tissue of your body, from tissues inside your body, and it may be because of the defense system, problem with the defense system, where there is extra deposition of fibroblasts or fibers, or tightening of the skin tissues inside across the body. I don't know what I'm saying. So yeah, and right now we will try to admit you, and we will try to involve a specialist team of doctors, ranging starting from the joint doctor, the skin doctor, the heart and the lungs doctor, and they will run few tests, and they will be in better position to let you know. Any other concerns?
Uh, no, doctor. No, doctor, thank you.
Okay.
Okay, examiner question, Dr. Doria, you can start now.
Okay. What is the differential diagnosis?
This looks to me a connective tissue disease. This is a typical case of connective tissue disease causing interstitial lung disease. And in your
Okay.
case, yeah.
Okay, continue.
In your case, it looks like that it's a scleroderma, which is causing the lung disease, interstitial lung disease.
Okay. What is the
Yeah.
other differential diagnosis for interstitial lung disease?
So
And
I
how
mean,
can we divide it? And how can we divide it into interstitial lung?
so we have the one which we call idiopathic. Idiopathic. I mean, mostly in high elderly people. And the one is the connective tissue associated interstitial lung disease. It's secondary to other conditions like joint conditions like rheumatoid arthritis or systemic sclerosis. And there is another differential, which we know as the drug-induced. These are the differentials. And yours seemed to be a case of a scleroderma. And it's of two types, limited and diffuse type.
Okay. About the skin lesions, that skin change that occur in her finger. What is the name of this skin lesion?
About skin changes, the tightening?
Yes, skin change that occur in her finger, in the patient finger. What is the name and what is the type of these skin changes?
Oh, that's called Raynaud's. That's called Raynaud's phenomenon.
Okay.
Yeah. So it's primary Raynaud's, the one that occurs without any baseline condition, without any underlying condition, and the other is secondary Raynaud's that occurs in those people who have underlying conditions like underlying connective tissue disease.
Okay.
Yeah.
Okay. How can you investigate this patient? What is the investigation that should be requested in this case?
Yeah. So the patient is having problem with the breathing. So we will try to do oxygen saturation first, and I mean, ideally from the bedside, we'll try to do the sputum culture as well. Although it's dry, we'll try to do that as well. Then we can do imaging. We'll start with the chest X-ray. We can move to HRCT to see the changes in the lung, which can be honeycombing, or which can be ground glass opacities based on the conditions it may be having. And we can do PFTs, pulmonary function test, to check the pattern, whether it's an obstructive or restrictive pattern. Most probably it will be a restrictive. Then we can do serologies to do ANA and anti-CCP and anti-Rho, anti-LA, and yeah, we'll try to do these tests. Then we can do urine electrolytes. We can do urine RE to check for the involvement of kidneys. Yeah, these are tests we'll be doing. And since there is a swallowing difficulty, we can do esophageal barium follow through. We can do that to check whether or not there is any other problem related to esophagus or not.
Okay, doctor. How come you manage this case?
We can manage it through involving multiple specialists and making a specialist team and seeking support of SALT team, speech and language, and yeah, and we would be doing first of all, we will be doing education and counseling of the patient, making multiple specialist team, making an MDT, multidisciplinary team involving different doctors, and educating the patient that the patient should be using warmers when exposed to cold environment. The patient will be given list of medications which they cannot use as it can aggravate the condition. And yes, and based on the underlying condition, the patient can be given to use certain medications like AC inhibitors to prevent crisis. The patient should be advised not to use steroids as it can aggravate the crisis. And yeah, and they can be given calcium channel blockers. So it can help in avoiding the Raynaud's phenomenon being aggravated with the exposure to cold. So yeah, this is what we can do.
Okay. Okay.
Thank you. Any other question? I think time is up. You can comment now, Dr. Doria, please.
Yes. He doing well. He covered all aspects of his history. He approaching history in a very good way. Also, in history, in examination, I think that he missed some points in hand examination. He missed the Raynaud phenomena. As I said to him, I have a change in the color. He did not comment in it. Okay. Also, I think it's the only thing that have been missed by him. Is Raynaud, absent Raynaud during examination, but overall, his approach is very good and very nice.
Okay. Thank you, Dr. Doria. Any other comments you want to add? So the diagnosis, it's scleroderma or systemic sclerosis, right?
Yes.
As he have mentioned.
Yes.
And it's associated with other autoimmune, like systemic sclerosis, or just autoimmune Raynaud? Any antiphospholipid positive?
No, it have a Crest syndrome. I mean that it have a Crest syndrome. When I said dysphagia and I said Raynaud, I mean that it's Crest syndrome. Limited scleroderma.
So it was Crest syndrome.
Yes, Crest syndrome.
Okay, and the fingers change was Raynaud, or is it calcinosis?
No, Raynaud phenomena.
Raynaud's, okay. Anything else he missed? Antiphospholipid, was it there? Because he asked about the kids, but he didn't ask about miscarriages, right?
Yes. And
Was
he
it
does not
positive?
ask about his kids. Yes.
Was it positive in the history?
No. It was very negative in these patients.
So no Raynaud. Sorry, no antiphospholipid.
No. Yes. No,
Okay.
no antiphospholipid. Yes.
Dermatomyositis and systemic sclerosis, was it there?
There is no dermatomyositis in this case. I think Crest syndrome.
So it was a case of Chris syndrome without any other complication or association.
Yes.
Okay, and the lung condition is interstitial lung disease,
Yes.
fibrosis mainly, not as other pulmonary hypertension. No association for pulmonary hypertension, right?
There is association with pulmonary hypertension. I said to him, has palpable B2 and audible high B2. Also
And
Yeah.
patients.
yeah,
Yes.
perfect. And did he picked up it in the examination?
Yes.
Okay, so the case now clear, Dr. Ibo, but I think the time management need to be adjusted again. You missed the examination if you didn't finish before the time, as well as the concern, right? So you need to be faster and the history taking. Try to correlate the things, the positive finding, because you didn't correlate all together. Why this patient is having difficulty of swallowing, along with short of breath, regurgitation. What do you think the cause of his or her regurgitation, Dr. Ibu?
Yes,
No, no,
Regurgitation.
let him. No, wait, Dr. Dre, he will answer this.
it's dysmotility.
Sorry.
Dysmotility. Esophageal dysmotility.
Exactly. Yes. Yeah. Okay. And how to treat it?
Uh,
How
with
to screen and how to treat.
you will do the manometry,
Yeah. Perfect. Okay. And motility study. Okay. What and how to manage?
and then we can do medications like blockers, calcium channel blockers.
Calcium channel systematic. You mean right?
Yes,
Okay. Anything else?
and then if it's I think that we should be doing
Only systemic medication. Any endoscopy to be done?
dilatation. We can do when it's required.
I don't think it's dilatation. It's a matter of narrowing variable areas of narrowing and dilatation. So maybe in the area of narrowing, they can do dilatation. But I think I'm not sure really about how to interfere with the systemic or this motility disorder as endoscopic or a surgical management. If Dr. Hind with us, she can tell if there is any update.
Yes,
Or
The
yes,
treatment you mean of
yeah,
dysphagia?
the dysphagia or motility disorder and the systemic sclerosis.
Nothing can be done except prokinetics and PPI.
Yeah,
Usually,
exactly.
yes, medical treatment, and it is not a treatment, it's just symptomatic relief.
Symptomatic relief,
Yes,
yes.
prokinetics will help to enhance the motility sometime. And as we said, PPI, and also dietary, lifestyle changes like small, frequent meals, taking liquids with a solid. Some techniques will be taught by the SOL team about the swallowing issues. It will help. And mainly, and this motility will affect the esophagus, will stomach, will bowel, and nothing can be done. Not much. If you control the systemic sclerosis, even this will not change the outcome. There will be continuous worsening. To extend, you have to tell this to the patient, and there will be a progression. Nothing can be done too much, especially no surgical intervention.
So treat the underlying cause, yes, as you said. Okay, thank you, Dr. Hind.
Have
Yeah. The concern, Dr. Ibu, remember, 2 minutes left while examining the patient. Even if you don't have the time, focus to finish the concern while examining the patient. May I know what's your concern? Straight away, while doing the examination, address it. Doctor, will I die? I'm so sorry to feel that, but as you have a condition could affect your life because of the lung issue, I'm afraid to say it might be affected. Your life might be affected if this progress affecting the lungs while examining the patient. Okay, so be sure that you address the concern earlier. Otherwise, the 4 marks, no mercy in the exam. If you don't ask as a question any concern, no one will help you to give even 1 mark. At least show the examiner that I'm concerning and I'm worried about his concern. I should ask about the concern. If he, at least if you ask this question, the examiner will say yes, he doesn't have the time because this is a complicated case. But if you don't ask about the concern, I'm afraid to say that he can give you unsatisfactory 0-0 in both examiner. And sometimes the skill as concern fail some candidate. I know one candidate or more who failed in the whole exam because of the concern skill. So don't overlook 2 minutes left without asking your concern. Do the examination. I'm not saying don't examine the patient. No, examine the patient. At the same time, ask for the concern. Answer even one concern. You might have 1 mark, 2 marks better than 0. And this mark, again, sometimes you might fail the whole exam with 1 mark in one skill. And this is what happened with the candidate I am saying. She failed the exam because of 1 mark in the concern. So the pass mark was, for example, 11. She got 10. And she failed all the exam. How much the depression you feel if you have failed because of this skill and this mark and this skill in particular. Okay. Okay. So the case is straightforward for systemic sclerosis, Chris syndrome. I think no more comment. Anyone want to comment regarding this case? Okay, Dr. Nada is writing Chris syndrome apart from limited cutaneous systemic. So I think it's not associated with interstitial lung disease. Correct me if I am wrong. Yeah. Okay. So let's talk about 2 types. We just have the topic last week. We have 2 types of systemic sclerosis, either the diffuse one or the limited one, right? The diffuse one will affect the all internal organ, including the lungs, the kidney, right? And the intestine, the gut, the bowel. While the limited one, if affecting the skin, will be only below the elbow, but the lung will be affected through the pulmonary hypertension. You're right. So the interstitial lung disease will be more with the diffuse type.
Yes.
But yeah, but again, interstitial lung disease with the time will lead to the pulmonary hypertension. So both cases can be associated with the pulmonary hypertension, but the internal organs will be more affected in the diffuse type. Okay. Any other question or comment?
كلمتك كتير مهمة إنه more it's a matter of predominant feature.
Yeah, predominant.
It's
Yes.
it's not a matter of if I have limited, I will not have. Even in limited crest, you might have scleroderma renal crisis, which we are expecting to see it in diffuse. Usually, even I notice in rheumatology, they never ever write for you in the file of the patient, this patient of diffuse, this patient is of limited, this patient is of kaza. Why? Because there is a big overlap and you have to monitor the patient, he will keep progressing. Therefore, it will not make a difference whether he is diffuse or limited. This is a viva question, theoretical question, just to show the examiner that you're aware of the staging of the disease. And to be honest, also في فكرة كتير حلوة اللي هي إنه when you will pinch the skin. Recently I understood إنه first, what is the definition of sclerodactyly?
Tightening of the skin around the digits.
Around the digits, not exceeding the line of MCB. يعني أنت if you have just a sclerodactyly, let's say early systemic sclerosis, if you will pinch the finger, tight skin. You will pinch the dorsum of the hand, normal skin. What is what we call this? We call it early systemic sclerosis, just sclerodactyly. Okay? Now let's say that you pinch the skin and you find that there is also tightness of the dorsum of the hand. Okay? At this point, you cannot differentiate between limited or diffuse because you don't know whether it will progress or not. But still, we are acting in this exam. So we will do pinching of the skin where and where to confirm.
The elbow, above and below the elbow.
عليك نور, above and below the elbow,
Yes.
and do this even in the legs. لأنه you remember Dr. Salah, he used to, and really it was interesting, إنه sometimes this differentiation can be made in the lower limb, but you cannot make it in the upper limb. The disease body involving lower limb أكتر. So when you do pinching of like the foot and over the trunk or over the upper thigh, you will be able to illustrate, but in the upper limb normal مثلا. تمام. فalways try to do it in the lower limb, also in the upper limb, and in the trunk, على sternum. تمام. Because if we saw the illustration of the limited and diffuse, the trunk is spared بالlimited. تمام. Also pinching the trunk is important. It's really like a technique, let's say, and everyone will really watch how you are doing it. Remember إنه when you pinch the skin of the hand, you should not just put your hand over the dorsum. You should also pinch the spot, like 2 fingers, for example, especially if you are sure in this case you are dealing with a systemic sclerosis. And please always remember, when you practice, keep this I will take the permission before I pinch. Okay, and try to take a permission for yourself to pinch. It's not like when you check the pallor. Checking the pallor, you can ask the patient to do it. Please move your lower eyelid below, flip your lips to see the gum and this stuff. But for the pinching of the skin, it's very important to do it yourself so you can decide. وصحيح يعني على ذكرى بيجي ذكر شيء تاني. Dr. Apple, like this question for you. What conditions we need to pinch the skin?
In what conditions we need to pinch the skin?
Yes.
One is this, the scleroderma,
Agree. What else?
and because it is called calcinosis. Skin pinch test.
And they are always diagnostic. Pinching the skin is always like, it's concerned with the diagnostic criteria. So you should remember.
That is the Marfan's?
Yes.
Marfan's?
Ehlers-Danlos syndrome and
Ehlers-Danlos
Marfan.
syndrome.
Yes. Overstretchability of the skin.
Stretchability.
Where else? In steroid, what you will find?
That will be striae.
Thin paper, cigarette paper like skin.
Yes, thin.
Or in Cushing. So you need to pinch the skin in Cushing or iatrogenic Cushing. You need to pinch the skin in collagen diseases like Marfan, Ehlers-Danlos, Pseudoxanthoma, elastica. Okay, and you need to pinch the skin in scleroderma. Sometime, very rarely, I don't know if they repeated this case in diabetes. Chiroarthropathy also, you find that the patient has localized stiffness. It's called chiroarthropathy illa. So this will also like in diabetes, but I feel it's like rare to come in the exam. Once it was discussed and then later on we never heard about this case. Remember to pinch the skin, please, and remember to pinch the skin in scleroderma, as we said, below, above the elbow, below and above the knee, and in the trunk, after taking permission from the patient. There is an interesting criteria, Kauno. I advised you to check the criteria, listen to it very carefully, because most of those criteria, if you didn't comment on them and the case is scleroderma, really you might find this in the feedback. The first criteria, it's 2013 ACR EULAR criteria for scleroderma. Skin thickening of both hands proximal to MCP. Imagine, by itself, it's enough to diagnose scleroderma without anything else, even without joint pain, without telangiectasia, without anything. It takes 9 points. Just this sentence. That's why pinching the fingers is very important. Skin thickening of both hands proximal to MCP. 9 points alone is sufficient to diagnose scleroderma. Then puffy fingers. And this is a very early sign of scleroderma. تمام. puffy fingers. And if you look for scleroderma in Google images, you will find some images, puffy fingers. Just the hand is really swollen. Okay, and shiny sometime before the tightness. Then scleroductily. Okay, scleroductily, the one we talked about, skin thickening distal to MCP. I'm sorry, yes, when I was talking about the first criteria, it's about the dorsum of the hand. I'm sorry. The first criteria, pinching the dorsum, because it was talking about proximal to MCP, and it is usually 9 points. Okay, this criteria is scleroderma, where you need to pinch the fingers. It takes just 4 points. The one at the wrist is the one which is diagnostic for scleroderma, and it takes 9 points. The one at the finger is just a scleroductily, and it takes 4 points. تمام. Then fingertip ulcers. You might find active ulcers.
Yes.
You might find healing ulcers. Okay, because you're talking practically. So look for both. Pitting scars, okay, which is sometimes healed, but because the skin is abnormal, so it will leave pits. Okay, abnormal healed ulcers or abnormal healed scars for trauma or something. تمام. telangiectasia. And where exactly you should look for the telangiectasia? Always look for telangiectasia where?
Around mouth?
Around the mouth and inside the mouth and under the tongue and in the palate. Okay, because sometimes it's not obvious in the skin or treated تمام whatsoever. So whenever we talk about telangiectasia in HHT or systemic sclerosis, it's always like in the mouth. Abnormal nail fold capillaries. And what you should offer?
Oh, yes.
What you should offer?
Yes. Capillaroscopy, bedside.
Yes. Now
I forgot it.
capillaroscopy is like when you offer fundoscopy for diabetes. Okay, like now they are the 3 trendy stuff: otoscopy in meningitis, fundoscopy, this trend we know before, whatsoever conditions we need to offer fundoscopy, a capillaroscopy in connective tissue diseases, because whether it's systemic sclerosis or overlap or mixed connective tissue disease, I should offer capillaroscopy. تمام. bedside. If I forget, in the investigation. تمام. Then pulmonary artery hypertension and interstitial lung disease, 2 points. Okay, and then Raynaud's phenomena. Okay, and even Raynaud's phenomena, it need a capillaroscopy, because if it is abnormal, it will be secondary. If it is normal, it will be primary Raynaud's. Okay, then systemic scleroderma related antibody. So the serological markers are part of the criteria. Okay, you need to tell about anticentromere, antiscleroderma 70. The other name is topoisomerase, and you should remember both names, please. So antiscleroderma 70 is a synonym for topoisomerase 1. And the third antibody
RNP?
are not you want RMP for mixed connective tissue disease. I need a very important marker for systemic sclerosis, especially when I have interstitial lung disease and pulmonary hypertension. Not only anticentromere and antiscleroderma 70 or topoisomerase. What is the third one? Which we usually forget. That's why I really wanted to discuss. Anti-RNA polymerase
3.
is okay. And if there is any overlap or mixed connective tissue disease, you will mention the other markers. Now, this is not a details. Why? Because it's part of the criteria. You never ever, always, if you want to understand what is the difference between someone who is like just illustrating knowledge or giving you something, if it is part of the criteria, then I have to mention it. Okay, because no diagnosis without a criteria, and thankfully there is a criteria, so I need to fulfill it. So the serological markers have to be mentioned, and then you will add whatever RO, don't say ROLA, ROLA. I need to mention for the mixed connective tissue disease, أنا طبعا always is important, and this other stuff, whatever for the like full autoimmune profile. But these 3 markers have to be mentioned. A total score of more or equal to 9 classify the patient as systemic sclerosis. Okay? And also you need to know that the opposite is correct. If I find thickening over the wrist, it is enough to diagnose systemic sclerosis. But at the same time, with all these criteria, if I fulfill 9 points without skin thickening, still I can establish diagnosis of systemic sclerosis. So the new criteria are supporting the idea that systemic sclerosis can happen without obvious proximal thickening of the skin. Okay, you can diagnose it based on Raynaud's phenomena, abnormal nail fold capillaroscopy, interstitial lung disease. I mean, those combinations are alarming for systemic sclerosis. Fingertip lesions, positive antibodies. Okay, because I can collect those 9 points from any other criteria, or I can just get them from pinching the wrist, the skin over the dorsum of the hand. Okay, so just like keep these criteria in your mind, and the peripheral criteria, before they used to call them also pulp atrophy. I remember also there is all the criteria, and it was mentioned by name pulp atrophy. So here in the criteria, it's not mentioned fingertip ulcers. Between two brackets, mention pulp atrophy for yourself. Then add calcinosis, add the other stuff. But those are part of the criteria. And add to them whatever you should know. And remember that the skin rash in scleroderma can be what? What are the types of skin rash in scleroderma, Dr. April?
For what? Sorry?
Skin rash in scleroderma.
Telangiectasia
Yes.
and salt and pepper
Yes.
and pitting ulcers
We can call the fingertip or pitting ulcers because those are
on the
also types
fingertips.
of, yes. And if there is any overlap with the dermatomyositis, SLE, you will saw also those typical rashes. But salt and
Buttons.
pepper, yes, salt and pepper is very important. And we have sometimes scleroderma, I think salt and pepper, and usually it is like in the scalp, in the face, in the back. It can happen anywhere, okay? But we many times forget, and once because we don't know about salt and pepper rash, so one candidate he diagnosed vitiligo with scleroderma because of those hypopigmented areas, which is the salt part of the rash. So just go and look it up and try to know that this is a salt and pepper. If you find it, it is supportive of scleroderma. So just those stuff. I hope they were helpful, yani, because scleroderma is a very common case actually.
And I feel like repeat telling. I feel like a deja vu. That I feel like it happened. This case was even last week or before last week, maybe. And
Yes,
Dr.
Dr. Basim, he mentioned that you
Dr.
people
Basim
discussed. Yes.
and you as well. I think Dr. Hind, you were also there. Also explained.
Uh-huh. Did I mention this stuff before؟ والله
Yes.
ممكن. ما أنا
Yes.
مع الدمنشيا اللي فيها.
Maybe I know I'm dementic because I'm feeling that maybe Dr. Basim can
No,
tell
but
us.
do you know if you really heard them again? But for me, I felt it's a chance to revise, but maybe you are right, wallah. Wallah, I don't know. Now you
Dr.
are
Basim can testify.
still
Yeah, yeah,
impatient
it was
فيهم.
last week. Yeah, last
It
week.
was last week. Yeah,
والله عن
يعني
جد وحكينا فيهم حكينا بالسكور.
It wasn't the all details, but it was the same case.
almost the same case. Yes.
Yeah, it was almost the same. Or same topic
Okay,
actually.
maybe.
Yeah.
بس والله أنا صايرة عم بنسى يعني. Anyway, I hope it was.
No, I forgot it. In fact, I
Okay,
was like thinking that when this came to me, I was like, oh my God, this is going to be easy when she said the fingers are turning. And plus, how can we describe this to the patient? How can we describe this limited?
Yeah. The good question, because I noticed that you didn't explain
I
it
did
well.
explain it. I got stuck totally.
Yeah, the same defense system disease that attacking your multiple areas in your body, including the fingers. That's it. No need to mention the tissue or whatsoever. Just
But why are the
attacking
fingers tight, sir? Don't
the
we
same,
need
the
to
same.
mention that? The
Yeah,
same?
well, the same. Yes,
Okay. Okay.
because of attacking your fingers.
So you can say just it lead to stiffness and hardening of the tissue. Because scleroderma
Yes,
is stiffness and
yes.
hardening. And as long as you have hardening of the muscles, there will be this motility. Hardening of the skin, there will be thickness. Hardening of the and stiffness in
Yeah.
the lung tissue and the blood channels, there will be interstitial lung. So it is a stiffness and hardening, increase in the stiffness, or the tissue become hard and stiff due to this misdirected immune defense, and it's affecting many parts of your body, leading to
Yes.
problems. For example, you can give her some examples whatsoever, and this is what we call systemic sclerosis. Unfortunately, it's a progressive and it has no treatment, no cure. Our treatment mainly aim at monitoring for complication and managing you symptom-wise. And if
Yeah,
there
and
is
reduce
pulmonary,
the
to
yeah.
reduce.
Continue.
لا عادي
The
كمل to
progression.
reduce.
I mean to reduce the progression of the disease.
That will to reduce
Some
the
medicine.
progression because whatsoever you will give scleroderma will never stop progressing. تمام يعني it's usually just mainly symptomatic, and to avoid maybe يعني مثلا لو أنا عندي pulmonary لو عندي مثلا hypertension, scleroderma, renal crisis. So if I manage the hypertension, I'll prevent the attacks. But do you think إنه any medication we usually offer حتى تبع interstitial lung disease, even the pulmonary, usually it will not change the outcome, but it will try to limit the complication, limit the consequences of the complication. للأسف حتى وقت بتقرا بالمونيتورينج تبع السكليروديرما, imagine you are not monitoring to achieve remission. يعني هلا بالاس ال اي they are aiming at remission. بالروماتويد arthritis they are aiming at remission. in scleroderma ما بتلاقي في بالمونيتورينج aiming at remission. It will you never achieve it يعني. تمام. You're just aiming to keep the patient asymptomatic as much as
Symptom-free.
possible.
Yeah.
Yes, and if there is any complication, he will not suffer from the consequences. مثلا systemic renal
Yeah.
crisis, he will not lose his kidney. So at least I will try to control the attack, prevent the trigger, so the consequences of the complication will be minimized. But actually they will never يعني عن جد لما it's evident بالmonitoring there is no definition of remission for scleroderma. Otherwise بالother diseases as you said I'm giving treatment حلمي إني أنا أوصل لل decrease progression. But in scleroderma it will never happen. تمام. You can tell him progression, a progressive disease, and we aim at controlling the complication, controlling the symptoms, and يعني we will try to manage. الشغلة اللي كنت بدي أقولها, whatever I wanted to say, if this patient is a female and have pulmonary hypertension complication of systemic sclerosis, what we should be our major concern?
Pregnancy?
Yes.
Should never be pregnant.
So you should tell her, dear, since you are in the what we call childbearing age, I would like to emphasize on the emphasize on family planning. Okay, don't go in details, because if you will ask her, are you planning to be pregnant? Then no, I don't have time. I'll just tell immediately the fact. Since you are in a childbearing age and you have problems in the blood channels of your lung, what we call pulmonary hypertension, I strongly advise you to have a pregnancy planning. Okay, because this is important for your safety. That's it. Just one point. Okay. And this is very important. It is the same like addressing driving and hobbies and genetic counseling in HOCAM. Okay, so systemic sclerosis important because of its pulmonary hypertension and interstitial lung disease with dysphagia. Sometimes it comes just by the GERD, and you find that GERD is part of systemic sclerosis. So systemic sclerosis is full of scenarios. Okay, I try to do it very well.
I'm having dementia, and the only thing I remembered was Dr. Basim sir telling me about pregnancy loss. But when I saw the age of 64, then I forgot I thought that I shouldn't ask this question.
This patient, our patient today is 64?
Yes.
Okay, that's good. I asked
that was the only thing that I was remembering that I should ask about recurrent. I missed so many questions.
In your mind. خلاص, if it is in your mind, as you said, because of the age, I agree. Even like it makes sense to do you know, يعني, always evaluate what you should say, what you should not. So looking at the age in this scenario, yes, it will make it less significant, but it is always very important to remember. يعني keep all the information in your mind because you don't know what you will use. Okay, but use whatever is necessary in the exam. Utter whatever is significant. No, don't mention everything. If she's 64, I agree with you. It will not be of significance here. Okay.
Yeah, but the miscarriage as a history will be important.
Yes, because if
miscarriage
she
still
had a
will be positive.
miscarriage, it can be a
Yes.
past history.
That's important.
Yeah, past history. Yes, exactly.
And did you mention, Dr. Ipo, the management of Raynaud's and the instruction of
Yeah,
Raynaud's?
he mentioned to warm the hand. Yes, he mentioned.
Yes, I mentioned the warming the hand. I didn't mention the driving part, although, because I don't know it will cause a problem with the driving. Maybe it will. I don't think so it will cause problem with the
Yeah, but
driving.
the warming much better and important.
Warming, yeah, warming.
Yeah, the
I
warming.
mentioned warming.
The driving will not be that effective unless the patient has some impact on the driving. Otherwise, the warming will be the most important to mention.
Driving has not much importance in systemic sclerosis in general لأنه ما فيها vision syncope seizure ما فيها except if you have very severe stiffness of the hands to extent his fixed flexion deformity and he cannot drive safely maybe تمام at that time even don't stop driving tell him to notify the DVLA لأنه سبحان الله بيطلع لك modification لل steering, there might be a modification for steering, which can help him to drive. At the end, you don't want to stop anyone except after notifying DVLA. Yani even if you felt there is a kind of restriction, tell him please notify. They are in a better position to tell you about their own regulation or see if there is any modification can be done. تمام to help you drive. طيب سؤال, a very important question. What did you prescribe for this patient for Raynaud's, Dr. Ipo?
Blockers, calcium channel blockers.
I asked this question in order not to hear calcium. Why you cannot prescribe calcium channel blocker in this case?
I should prescribe. I think I prescribe. Are you saying that
it is the regular treatment for Raynaud's phenomena? But as we said, the information we know, we should really look if it's applied correctly to the case. Your case have GERD, right?
okay.
It's on PPI, and you will give calcium channel blocker. What will happen to the GERD?
Yeah, by the way, when for dysmotility, I mentioned calcium channel blocker. My mistake. That's a blunder.
Okay, but anyway, for the Raynaud's phenomena, you will do the instructions, warming of the hands and avoid cold stuff and these things, even for the legs and for the hands, because it's sometimes in both. And then you will tell her that we might look into, for example, we can give sildenafil. Sometimes ACE inhibitors can be given. I was surprised when I saw the option for Raynaud's phenomena treatment. Any vasodilator will work. But calcium channel blockers, sometimes they are like exacerbate the GERD. So take care. And sometimes even omeprazole can exacerbate diarrhea by microscopic colitis. These things are tricks. يعني I love them. But يعني PPI is too much advanced. Accessories yeah, for the case. But the calcium channel blocker is important. Think of the drug before the prescribing, okay? So you can tell her that this is the first line or there is other first line medication. We need to look for the best medication which suit your gullet problem, the reflux problem, okay? And if this patient is on OCPs, طبعا she's 64, so this will not apply, but take care, young lady, childbearing age, pregnancy, if she's on OCP, you need to stop them because they are also not they are not compatible with Raynaud's. They can worsen. So I love those tricks. So I made your life difficult with my tricks.
No, at all valuable. Thank you so much, Dr. Hind.
Very valuable.
Yes, of course. I want to add the prostaglandin, Dr. Hind, right? It can help.
Prostaglandins are used, prostacyclin, and there are now like advanced option which is oral. Yes, so he can use them. They will find for him a treatment for Raynaud's other than calcium channel.
Yes, exactly. Yes. Okay, but the warming will be the most important one ever. Why? Because the patient can do it by herself to avoid the cold exposure, and easily she can warm the hand whenever she has the phenomena started.
And if he is a male and is working as an engineer, operating heavy machines, most probably he will be using respiratory tools. So you have to tell him that please, vibration might make it worse. So try to avoid or like يعني keep it for someone else to do it rather than you. But don't be too much restrictive. بس يعني you should comment on any trigger for Raynaud's. Whenever Raynaud's is there, you have to ask about the job, ask about if she's a lady, whether she's cooking using any. لأنه sometimes he's a, and you tell him, please, for example, avoid cold. But you forget that he's working in as a fishman or like in a grocery or as in an ice cream factory. So always correlate, okay, between the job and the advices. I think in this case she was a teacher. That's worth revising, okay? Just like to be
Yeah,
careful.
yeah. Sometimes it's the job will be ice cream worker. Anyway, yes. So should address everything. Yes. Okay. Thank you, Dr. Hind. As usual, valuable comments. Anyone has question before ending the session? Okay. Thank you, Dr. Ibu, Dr. Doria.
Thank you, sir.
Again, you're welcome, Dr. Doria, at any time to practice, and everyone is welcome or she's welcome to practice. Thank you, all of you. See you tomorrow, inshallah, the
Thank you, sir.
communication day.
Thank you, sir.
Thank you so much. See you tomorrow, inshallah, the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you.